I have no relevant financial disclosures or conflicts of interest. So my objectives today are to review the typical Fontan palliation pathway, to discuss the complications that are related to Fontan physiology, examine the new recommendations for Fontan care, and describe the model that we've adopted here in Louisville to monitor these patients. So to kind of get everyone started and maybe engaged again after the break, we'll do some prediction questions just to kind of set the scene. So if everyone can either go to the website at the top, polev.com / Josh Kurt 620, or text to that information really quick. The first one will be: children with Fontan physiology are most at risk for which other organ system dysfunction? I'll just give you a couple minutes to. We've got at least one response, so it does seem to be working. Just like another few seconds. So we've got a decent number of responses, at least, just based on how numbers keep changing. So yeah, I can see there's definitely a smattering across here of kind of some different ideas, and that's good. That the answers, they're at risk for all of these, and we'll talk more about which one is most common in a little bit. And then just a second one, exercise capacity in those with a Fontan is how much compared to their peers. And this is another, unfortunately, issue with those with a Fontan. So yeah, this one seems to have a little more of a consensus. And yeah, it's unfortunately anywhere from kind of in the low mild to upper, or I guess upper mild to moderately decrease, that, somewhere kind of in the 50 to 70% range. And again, we'll talk more about this in a little and why this is such a big deal. So starting with our case, this is a 7-year-old boy who was born with double inlet left ventricle, crisscross atrioventricular valves, malpros great arteries, and hypoplasia of the aortic arch. You can see on the right side here, this is a diagram of his heart. Unfortunately, I forgot to draw the hypoplastic arch, so you can just imagine that the arch is smaller than the PA's. And basically what this means is both his mitral and tricuspid inflows are directed into a single left ventricle. The outflow chamber to the aortic valve, as seen here, is not a true ventricle, but just a remnant of the bulbo ventricle from fetal development, and really is just an outflow chamber. Depending on which school of morphology you listen to, this is the only true single ventricle. In addition to those intracardiac defects, as I mentioned, his arch was small and wasn't able to maintain systemic output on its own. And so because of all of this, he underwent a Norwood procedure with a 3.5 millimeter modified Blalock-Taussig Thomas shunt on day of life 6. And basically what this means is the surgeons went in and created a single outflow tract. And so they connected both the pulmonary artery and aortic arch to form a single outflow, augmenting the aortic arch to make it a normal size. So that all blood that left the heart was now directed towards the systemic circulation. There was then a 3.5 millimeter tube placed from the right subclavian artery to the right pulmonary artery. And this is what the Blalock-Taussig Thomas shunt is. And this is what supplies pulmonary blood flow. Essentially, it's a synthetic PDA. He did well in what we refer to as the interstage period, and eventually underwent a bidirectional Glenn shunt, which is an SVC to pulmonary artery anastomosis, and I'll show you in a second what that looks like. And then he finally completed the Fontan palliation with an extracardiac conduit, fenestrated Fontan at 19 months of age. And so what the Fontan completion in this case is an IVC to PA connection using a Gore-Tex tube or some other material to connect the IVC all the way up to the PAs. His fenestration was closed 2 years later. And so if you look at the diagram on the right, this is essentially what his heart looks like now. Again, there's the single left ventricle with both RA and LA inflow that enter that. They're then ejected out through either the native aortic valve or the native pulmonary valve, which we refer to as the neo aortic valve, out to the systemic circulation. And then blood returns through the SVC and IVC directly into the pulmonary arteries. So the reason for doing the Fontan palliation in these patients is it allows them to have a circulation in series, just like you or I would have. Unfortunately, in this setup, there are two resistance circuits within that series. And so the single pump ejects across both the systemic resistance as well as the pulmonary resistance. And this results in an obligatory rise in the central venous pressure to match that of the pulmonary artery pressure. And a number of the complications from this are related to that. In addition, some patients are left with a fenestration to allow their body to adapt to this new circulation, as this patient was. And this is basically a little connection from the Fontan circuit to the heart to allow blood an easier route out to the systemic circulation to maintain cardiac output. This is generally closed a few years later to prevent cyanosis, as it is the right to left shunt. And while this is what's done in the modern age, there's kind of been an evolution of the Fontan. And so when doctors Fontan and Kreutzer first described this, actually Fontan's first paper came out 50 years ago in December. What they had described was a direct connection from the right atrium to the pulmonary arteries. Unfortunately, this limited patients to only those that had no other egress from the right atrium. And so this had to be tricuspid atresia, and then they would close the ASD. And so all blood that returned to the right atrium had only one egress, and that was added into the PAs. This is later evolved into what is known as the lateral tunnel procedure. And this allowed more patients to undergo the procedure because now the surgeons would wall off the back wall of the right atrium so that all caval blood still used the right atrium, but now its only exit was again up through the SVC. And again, there was a connection from the SVC to the PAs, allowing blood to enter the PAs. Unfortunately, these both were fraught with frequent arrhythmias, especially the classic atrial pulmonary Fontan, which is one of the reasons that is lost favor. The most common procedure performed in the modern era is what our patient had, which is referred to as an extracardiac Fontan. And this is when the IVC and SVC are directly anastomosed or using some synthetic material or anastomosed to the PAs. As Mark Goelig describes this, one of the world leaders in Fontan, the Fontan procedure is not actually heart surgery. The Fontan procedure can be completely completed without actually touching the heart and is really just vascular surgery. So in this case, it's connecting the systemic veins into the pulmonary arteries. So keeping up with our patient, he was last seen a few months ago in clinic. He was a happy, active 7-year-old boy. He keeps up with his peers. He has no symptoms attributable to the cardiovascular system, including no chest pain, palpitations, syncope. He's not cyanotic. He has no swelling of his lower extremities or around his eyes. He has no problems eating. He can lay flat on his back. He's gaining weight appropriately. He eats a normal picky school-age diet, all by mouth. And his saturation in clinic was 98%. So from the outside, he looks no different than any other child who walks into clinic. But because of his severe disease, this is a rare disease, but it actually comes across the healthcare system much more. And so we should talk about just how frequent this is. The Fontan circuit itself is not actually a disease, but our palliation for it, used in a heterogeneous group of disorders that have very different ventricular and atrioventricular morphologies that all kind of converge on the similar surgical pathway. Combined single ventricle heart disease represents about 2 to 4% of congenital heart disease, which is anywhere around 35 per 100,000 live births. To put this in context, that's anywhere from 15 to 20 patients in Kentucky alone per year. Assuming most of these live now to be an adult, if you're a pediatrician, there are a few hundred Fontan patients living in Kentucky alone. Their healthcare utilization is quite high, which means that even as a general pediatrician or a non-cardiac pediatric subspecialist, there's a good chance that you'll come across one of these in your career. The good news now, especially as we say that, the prediction of surgery in the modern era is a 30-year survival of 85%. That's not something that could be said even 10 or 15 years ago. The downside of that is the Fontan circulation is characterized by a low cardiac output, venous congestion, diastolic dysfunction. It's a very inefficient circulation due to the lack of a subpulmonary pump, and this leads to dysfunction in almost every organ system. Here is just a brief list of the most common complications. As we mentioned, arrhythmias are upwards of half of the patients. This is much more common in the traditional style Fontan, but is still frequently seen today even in our extracardiac Fontans. Thromboembolic events happen about 1 in 5 patients by 10 years. And this is a surgery that's performed anywhere from 2 to 5 years of age. So at 10 years out, you're still only talking 12 to 15-year-olds. So young teenagers, where 1 in 5 will have some thromboembolic event. This is both arterial and venous thromboses. And recently, a study came out looking at Xarelto, which I'm sure you've all seen commercials for in adults with AFib. And then it's shown it's been at least as effective and probably will show soon to be more effective in thromboembolic events in Fontans than aspirin. I wouldn't be surprised in the near future if we start seeing fewer of these due to more modern anticoagulation that doesn't have the side effects associated with warfarin. They're at risk for renal insufficiency, exercise intolerance that we referenced at the beginning. Even the best Fontans usually have a peak oxygen consumption of somewhere between about 50 to 70% predicted for their age. There is a small group that does have a normal exercise tolerance, which we define as a peak oxygen consumption of greater than 80% predicted. And there's a lot of work going on right now trying to figure out what is different about those so that we can actually make all of these what we call quote unquote super Fontans. They're at risk for lymphopenia. This is kind of an unknown significance as they've never been shown to have any actual immune disorder. Lymphatic abnormalities, as a lot of people had listed in that original question with protein-losing enteropathy and plastic bronchitis. They're also at risk for endocrine disorders with bone demineralization, and one that I don't think is discussed enough is delayed puberty. But the biggest one is the effects on the liver. And this is why I left this at the end to highlight it. Fontan-associated liver disease is something that has really been noticed in just the last decade and even really 5 to 7 years. It's something that is quite frequent and nearly ubiquitous. The 2 major studies looking at biopsy results of patients with a Fontan circulation, a liver biopsy. The first one out of the Children's Hospital of Philadelphia showed 100% of the patients had some evidence of liver fibrosis 10 years post-Fontan. The second one done by Children's Hospital of Los Angeles only last year showed 96%. So this actually turns out there was only 1 patient in that group that did not have some degree of liver fibrosis 10 years out. So if you look at the 2 studies that are now totaling close to, if not over 100 patients, it is essentially ubiquitous that there's some degree of liver fibrosis. The problem with this is we don't actually know clinically how this impacts the patients. While those all have liver fibrosis, both by direct biopsy as well as some very ugly looking livers by imaging biomarkers, the course of clinical Fontan-associated liver disease is quite variable. And even those with what looks like a cirrhotic liver may have no symptoms of their liver disease, and even in some cases have shown regression after heart transplant. On the other end, there are some whose liver disease and fibrosis is not nearly as severe and have severe clinical signs of liver disease. And so this is one of the biggest areas of research right now, is trying to figure out how to prevent the end organ effects of the liver. Because of all these non-cardiac effects, the American Heart Association put a statement out just about 2 years ago about the evaluation and management of children and adult with Fontan circulation. And I'm gonna kind of unshare the presentation here just to read the quote from the conclusion really quickly. Given the relatively high prevalence and possible progressive nature of end organ dysfunction in those with Fontan circulation, in particular during their early formative years of organ growth and development during childhood, adolescence, and early adult life, a compelling argument can be made for performing serial surveillance of end organ status in patients with Fontan circulation is a relatively new concept. I think that exact paragraph was important to quote or to highlight is because for 50 years, these patients were out there and we had really looked at the benefits of this and thought, well, now they're repaired. And it's only been in the last few years that we've realized that there are a number of end organ deficits that occur as these children age into adolescence and adulthood, which has only happened over the last decade or two. And so I think it's important that we begin screening these patients, looking not only for cardiac dysfunction, but as well as hepatic, lymphatic, respiratory, neurologic, and renal function as well. And that's led many centers to start what they call a Fontan longitudinal clinic that's aimed at surveillance of these patients. And in the last year, we've started this in Louisville as well. And here's just to kind of highlight our plan. This is based on a lot of what was written in that paper, as well as a number of other centers. And we break it up into age groups. So those less than 13 years of age, kind of in those first 10 years post-Fontan, don't have nearly as much screening. As we know, that's kind of a honeymoon period where the end organ dysfunction doesn't occur as often. However, we do begin screening in that time. And all of them will undergo 1 to 2 screens within that kind of 5 to 7 year period. As we get into adulthood after 18, that screen becomes nearly yearly. But even in the adolescent patients, which a lot of you as pediatricians will be taking care of, this is the kind of screening protocol we have for them. It includes cardiac screening every year, exercise testing to look at their exercise tolerance, which has been associated with mortality risk as well as clinical risk every 1 to 2 years, liver screening with elastography, which is a measure of stiffness of the liver, as well as labs every 1 to 2 years. And then again, lab screening for all the other organ systems every year or two as well. And again, more frequently if there are concerns. I also want to highlight the kind of brownish orange section that psychological and neuropsychologic screening is very important. That is one thing that's even done more frequently in the younger group with a true neuropsych evaluation every 3 years, because we know the risk of ADHD, learning disabilities, and learning disorders, and other neurologic disorders are more frequent in this population as well. And so this is the amount of screening that needs to go into these patients to ensure that all the other organ systems are functioning normally as well as their cardiac system. To bring it back to our case, I think this is a highlight of just how well the Fontan circuit does work. Currently at his last visit, his systolic and diastolic function are normal. He has no signs of lymphatic abnormalities. He's just at his age, he hasn't undergone a liver evaluation yet, but is planning on doing it this summer. And we'll do our first stress test and cardiac MRI when he's able to at about 9 years old and able to cooperate. But the thing to highlight is just how well he's doing overall. And while we may not have kind of lived up to what Dr. Fontan thought in his original paper, and again, quoting the title, the complete repair of tricuspid atresia, I think we've unfortunately learned that this is still just palliation. This has given our patients an ability to live very similar to other children and giving them the opportunity to have as normal a childhood as possible, but still requires frequent follow-up and screening. Thank you, and I'll take any questions.
Josh, that was a great presentation. Looks like we have a question from one of the attendees. What is plastic bronchitis?
Yeah, so that's a great question. So this is an abnormality in the lymphatic system of the lungs, which causes lymph and chyle and other proteins to leak out into the bronchi, and you can actually form casts within the bronchus that are basically kind of a glue-like plug within the bronchus that causes difficulty breathing and respiratory distresses can be expected. What I think is kind of the scariest thing that you see at times is they'll actually cough these plugs up and you will see the shape of the bronchus in them. It's very clear that's where it is, and can be very difficult to manage, and unfortunately has a very high mortality rate.
All right. Any other questions from the attendees or panelists? So what are early common signs and symptoms of Fontan physiology failure that can be a red flag for you, Josh?
Yeah, so that's, unfortunately a hard one because they are so varied, but I think the biggest ones we start to see is related to that exercise intolerance. kids who were able to keep up with their peers or nearly keep up with their peers and are now getting short of breath with minimal activity, are limiting their own activity. I think that's usually a big one, especially in younger kids who usually don't realize their limitations and all of a sudden are self-limiting. That's usually one of the biggest signs that we see is as activity tolerance goes down, we start to get worried. The other one would be, kind of on a more objective measure, getting more desaturated. That's a sign that the Fontan circuit isn't able to maintain the full flow, and they're either creating new channels to create a right to left shunt, or if they have a fenestration left, they're using it more frequently.
All right, and for our attendees, do you have any common screening questions that can help our general pediatricians, even subspecialists, ask their Fontan patients to help optimize their management?
Yeah, I think, again, asking kind of those questions just about their activity level, their ability to tolerate, feeding, early satiety and decreased appetite is another, big thing we think of in right-sided heart disease or Fontan failure. Even just any change in the parents have noticed in activity level are usually the first things that I think as a general pediatrician would pick up on, that something's not going on, not normal is going on.
All right, great talk, Josh.